Vice President
Oration. You ask him to search as oration. Well, thanks for staying back. So this is my topic chosen, lifestyle as a prescription. So before I start, I think my respects to these great gentlemen. Many of them are here. I have worked with them directly, indirectly, and I've learned a lot from all of them, and I continue to learn from them. So my due respects to every one of them. So disclaimer, I'm not an authority on lifestyle. Lifestyle is a very controversial topic. I'm not a six-packer. I'm not an early starter. I just started some 6-7 years back. And what I'm trying to tell is, if I can get into it, anyone else also can do it. And I also would like to thank Credo Health for partnering in this journey with respect to patient care. And that's the data what people were talking about. I presented about 500 odd patients' data on how lifestyle modification changed. And that will be there in the end of the slide. So lifestyle, as I tried to understand, is a very, very complex entity. And it reminded me of this quote, famous quote from William Osler. I'm sure every one of you know this quote. Why I say that is, when I started getting into details of it, I was getting more and more confused. And then we started looking at it, it should be more a precision or personalized approach to each patient. Why I say that, as we go around, I'll tell you. So the flow is somewhat like this. So lifestyle is a complex entity. The nutrition, the physical activity, sleep, stress, behavioral habits, what we make, and the environment in which we live, all composites our lifestyle. It is not just about working out or dieting. So mindful eating, restful sleeping, wishful exercise, and above all, mindfulness and self-discipline. Self-discipline is the greatest of all this entity, what makes us sustain. Many people are motivated with me, but if you have to continue that, including myself, we have to be self-disciplined to a large extent. Having said that, today is a cheat day, so don't worry about that. So, and our health is just a mirror of our lifestyle. Even ADA, everyone knows this slide very well. I won't dwell into it for too detail. So this is important, and it has been encapsulated by ADA also. So is there a risk of inactivity is the question what comes. If you look at evidence-wise, meta-analysis of the studies, including more than about 11,000 patients, type 2 diabetic cases, have clearly shown if you are overweight or obese and physical activity is becoming a major determinant whether you get into converted to diabetes or not. So the increase is about 7-fold increase in the risk of developing type 2 diabetes if you're obese and inactive. So ask for activity. And I think I saw Dr. Hemant trying to show the yoga postures. Here we all, when we sit, it's been a long day, we can always do a solely as push-ups as we continue to listen to me. And that will also keep us going very well. So if inactivity is a problem, does increasing activity or improving the diet helps? We are in the era of evidence-based medicines. I don't know who will win tomorrow in the debate, but then of course we are in the era of evidence-based medicine. There is definite evidence that physical activity, why do we say 150 minutes? Because that is the duration of time when we advocate it to people, it helped in preventing the diabetes and its associated complications. Nowadays, it also says that higher the dose of the physical exercise, better the outcomes, and risk reduction of developing diabetes also comes down. Same thing applies to dietary restrictions. So that's what I was talking about, the exercise dose response curve. Whether it is love in the care of patients, If you are not able to manage, they say increase the dose of your love and affection. It works definitely. That's how the exercise also would work. And what they have shown is, if achieving twice the amount of recommended physical activity of 150 minutes per week, further risk reduction of 36% happens with respect to preventing type 2 diabetes in people who are at risk. We told that inactivity is bad, physical activity is good. We showed the evidence. How about our prescription says diet and exercise? I'll come to it in the next slide. But if you don't give a structured diet and exercise program, it is of no use. So this is the evidence what we have. Physical activity advice alone is not associated with any significant HbA1c changes. It's a composite of 14 studies. But if you give a structured exercise program along with diet, it works. So we are always telling you, you do some walk or this thing, but how much and what, it also has to come in our prescription. So that is the message I'm trying to give. So friends, we write a lot of prescriptions, which I've been discussing throughout the day. Lifestyle also should come as a prescription. And nowadays, we look at generic prescriptions, branded prescriptions. Now, beyond prescriptions, precision, which is the theme of our conference also, is important. Because there are hardly any takers for lifestyle measures when you come to manage diabetes. And if you look at, this is what we, at the most, with the time constraints, including myself, do diet and exercise, you do it, is what the maximum we tell. But that prescription is no different from showing that this antibiotic and painkiller. Because the previous slide I showed, if you are giving a structured program, it will definitely benefit. If you're not structuring it, it is not going to benefit as much as we assume it to be. So the components of lifestyle, we all know this. And I think this is a big WhatsApp forward. I'm sure everyone would have seen. One of the components of this lifestyle is the stool or the chair. We have been sitting for hours together even today. And also the sleep pattern and the screen, which is coming into a big way as our lifestyle problem. Actually, it was all started to help us, but it is going to be a problem for all of us if we don't regulate it. Let us talk about the most abused and addictive substance in the world. Which is it? Any idea? Food. Yeah, I have always a war at home when I talk about it. My wife is still smiling or grinning, I don't know. Anyway, food is the most abused entity. We don't account it. Exercise is the most underutilized antidepressant. Sleep, commonly impaired, uncommonly assessed, and rarely addressed. Screen, unfortunately, has become the new playground. This is what I told in the Madhumeha Patashala when I went to school. Unfortunately, the kids are playing on their screen. There is no physical activity, whatever we recommend it to be. So nutrition is very important entity. I won't get into the details, don't worry. What, how much, how, and when to eat, all parameters become very, very important. Some say love of food is the only pleasurable thing that can be enjoyed till the end, so let us enjoy it. My mom also says that many times. Other thing is we look for instant gratification or hedonic happiness rather than the eudaimonic gratification. So that is where the conscious works differently. Food also is an emotion. I come to your house and I don't eat. People feel so bad about it. Even if you've eaten and gone, you're forced to eat again. And for the loud ones, we tell you take more, you eat more, and then we actually are poisoning them. Sometimes I feel it is better to waste food. We should not waste. It is better to waste than to put on your waistlines. Especially the ladies at home, they do that. Why to waste? And then we have it, and then it comes on your waistline. So friends, kitchen is the largest pharmacy which is underutilized. So again, Sanjay Rao sir will keep telling you, take away all my sayings. So this is one of his, we are what we eat and also what we drink. And stop eating this crap is what the advice in simple terminology, what we need to give. So why did I say how much, how, and when to eat? We all know people come to us diabetics, I have stopped rice. Is ragi so good? Or wheat so good? Or rice so bad? Again, if you tell, this is an era of millets now. The same ragi, if you eat it as a roti, or a mudde, or the ragi ball, or ganji, or the porridge, it makes hell of a lot of a difference. And I had shown to my own family members, my mom, after putting CGMS, how a ragi ball can skyrocket your blood glucose much more than the rice. So because I always tell you, take away the ragi mudde and make ragi rotis in it. One mudde will have 4 rotis or plus based on the size, which we won't eat otherwise. So it goes easily. Whatever you can take it easily is always a poison. Again, we talk about sugar, jaggery, and honey, fruits versus juices. I will not get into the total details of it. Comparing cereals, if you look at it calorie-wise, there is slightly, ragi has less calories, but it is not very significant. Why people talk ragi is good, very good, is because of the component here, the calcium and iron and the mineral content, much more than the carb or the fiber content, which is almost the same. Same thing with sugar, honey, and jaggery. Why is jaggery so good? Naturally available. Again, the vitamins and minerals component of it makes it a difference. Not so much of the calories or the carbohydrate component of it. So this is what in simple I would like to tell. Then we always ask evidence again. So is there evidence? The landmark lifestyle intervention program, we all know the Look Ahead trial, where they looked at calorie restricted diet and reduced intake of high glycemic index diets. What did it say? At 11 years, the participants who benefited, who followed this regimen, were losing 5% of their weight, and they were fit, at least physically and mentally more fit. And there's a significant difference in the A1C and the blood pressure and the lipid profile parameters. Of course, mortality didn't show much of a difference, and it requires possibly more data into it. It's cluttered there. So my medical nutrition therapy evidence in India, yes, there is evidence in India. Sorry for the slide. I think it also clearly showed the reduced risk of progression of impaired glucose tolerance into diabetic. We all the nurses study, nurses welfare program. Similarly, Indian evidence is also there to say that there could be a significant benefit by following the medical nutrition therapy. So I'll stop for nutrition there and move on to exercise. Exercise is physical activity is much more than exercise, plus what we do as activities of daily living. We also have a lot of people who do exercise for an hour and they are sloth bear for the further 23 hours. That's why they don't get the desired effect. So keep moving, and exercise is a planned, structured, repeated regularly with a purpose. When I was trying to run a marathon, I had a different exercise protocol. When I'm trying to build a body, it is a different protocol. So that precision component should come into it, is what I'm trying to say. And as we all said, nowadays, sitting is considered as the new smoking. So some people are fit, but they succumb to so many problems. Everything is highlighted, gym deaths and sports person's deaths. So marathon fit, mountaineer fit, or bodybuilder fit, but are you metabolically healthy also? At what cost are you doing it? So we need to strike a balance with all these things. I think for the want of time, I will not get into the aerobic versus anaerobic exercise. Nowadays, we are, especially in diabetes, talking about muscle building, because we all know it improves the lean body mass and also works better on the insulin resistance parameter to be curtailed. So again, benefits of exercise, they have acute and long-term benefits. For example, when we are doing acutely, we have a increased cardiac output on the cardiac. But if there is a chronic adaptation, even the VO2 max, there's the oxygen extraction capacity from the blood is better, pulse rate comes down, stroke volume increases. So similarly, many of the changes shown here happen here. Muscle building will also improve the muscle resistance and improves the glucose uptake, and improved muscle mass improves insulin sensitivity. So benefits of exercise is not just restricted to that. Name it, fractures, cancers, coronary artery disease, everywhere the benefit of exercise is seen. The latest thing in the Journal of Sexual Medicine, October 23. This is an interesting finding. I think Bobby Matthew didn't show just this slide and he told everything else maybe. So exercise is the new Viagra. What did they find is exercise is as good as adding Viagra. Aerobic exercise benefited more, and degree of ED correlates directly. If the worse the ED, better the exercise, better the outcomes. And they have an improvement 0.2 scale where it showed as much improvement as testosterone supplementation in the treatment of erectile dysfunction. Yoga, my good friend Hemant gave a beautiful lecture. This is copied from him. Again, I'm not an authority on it. I keep visiting him, but I'm still yet to convert to becoming a bit more yogic type rather than the exercise type. So is there evidence here? Yes, definitely. Total RCTs are 27, 13 meta-analysis. What they conclude is yoga is definitely beneficial. 0.84% is the HbA1c reduction because of yoga, as good as any of the available oral anti-diabetic agents. And every additional increase in yoga practice again has an additional reduction of HbA1c by 0.22%. So variety is the key. So always mix it up. If you keep running, you will get into a lot of other injuries. If you're doing bodybuilding, you get other types of problems. So mix and match, flexibility. That's what the RSSDI guidelines also says, which I come to it. So if you're looking at the blood glucose in a diabetic during exercise, the level 100 to 250 is more reasonable for them to work out. If you go too low, better to supplement carbohydrate. If you are too high, with or without ketone bodies, it's a bit more risky to do the exercise. And of course, if you do intense exercise, more of the anaerobic exercise, you can have hyperglycemia also. It's not that every time the glucose comes down, because of the sympathetic drive, you can have hyperglycemia due to exercise. So avoiding hypoglycemia in diabetics, if you're doing a mixed exercise, it is shown that resistance exercise followed by aerobic exercise minimizes the risk of getting hypoglycemia. Avoid exercising in diabetics in the late evenings so that the nocturnal hypoglycemia risk comes down. So these are the two important points. The rest are all quite self-explanatory. And again, we are talking a lot about interrupted sitting, which is a promising exercise intervention. And the other one which I didn't allude to because of the want of time is the soleus push-ups. Again, still we need to have some data whether to how much of soleus push-up is useful, and we still are in the way to figure it out. So I do sometimes the crazy things. I usually sit in my clinic in the yoga ball. It helps me to keep my core tight. It also makes me get up and move around and examine the patient, as Madam Lily John was telling. Touching, feeling is the most important crux of it. And it gives me a lot of balance, and even the core strength has improved because of that. Again, you can try it, but then you try it slowly, almost 2.5 to 3 hours. I sit on yoga ball and then see the patients. So what is the RSSDI recommendations? So we all know adults 150 minutes per week. No more than 2 consecutive days of break is important. At least twice a week, include resistant training and avoid sedentary behavior. And again, off late, they include flexibility and yoga to be important ingredients. At least twice a week, we need to follow it. So American College of Physics, Sports Medicine is the one who started telling that exercise is a drug which is to be like a drug to be prescribed in the format of dosing, timing also, like how we prescribe exercise. Then comes the point of, are you fit to exercise? Fit for exercise is the most important entity. So we need to classify our patients if they're high risk versus low risk individuals. And we don't think about the mindset, if that person has really a mindset to exercise or not. So we need to work from there. No intention to already in training is what we need to categorize. I'll show it in a brief in the later part of the presentation. And basic tests are definitely must. One of our cardiologists said, do CT angiogram for everyone, definitely not needed. It is indicated in few of the people with a slightly higher risk, and my intention to run full marathon within 5 hours. I did CT angiography, but then I forgot to train for the marathon. So it also happens that, and it's good to accept that rather than brood over it. So pre-prescription is very important. We waste money on so many things. Always make it a point, if someone is getting into exercise based on the risk categorization, always get a clearance for exercise. And on special situations, yes, retinopathy, if the someone has undergone laser treatment, try to avoid exercise for the first 3 to 6 months. We all know exercise can cause physiological proteinuria. That also has to be kept in mind. And if there is a heart disease and uncontrolled BP, extremes of temperature and extremes of pulse rate has to be modified. Motivation is the most important thing. We may get started. There are a lot of my friends, colleagues, patients who get inspired seeing me running, but to stay there is very difficult. So how do I do it? If you look at the WhatsApp group, the one group which I always connect to it is the fitness groups. And then keep variety to your exercise, participate in some events, and have some fitness gurus with you who are into this, and they keep motivating you to continue. So the exercise prescription has to go like this. You look at the mindset of the patient, if he is not at all active, but he has intention or not, and if he is active, what is the level of activity? And then the fit principle comes in, and then prescribing. Before that, the foot has to be seen very importantly, assessed for neuropathy, how he is, and selection of a footwear also is very, very important. I won't go into the details because of the want of time. So some people come up with diet versus exercise. It is always diet with exercise. You can't outrun your fork. Diet, if individually, diet definitely matters much more than exercise. But I can clearly differentiate a day when I exercise to a day not exercise. When I exercise, I don't feel like eating junk. From my Manipal Hospital, -1 to 11th floor, I walk up. Few of my PGs don't like coming with me for rounds because of that. But the day I don't exercise, I don't do these two things. Because of the hormone, what happens, the happy feeling and the negative things about craving gets taken care of on the day when you exercise. Can exercise be stressful also is a question. Sometimes we get into this mode of too much doing and it can be stressful. It has happened to me also. You get more agitated. I'm sure Ravi Kirti can relate to it. So what I tell is, if you get up in the morning and if you don't feel rested, don't exercise. Relax. And don't brood that you didn't exercise. Enjoy that rest day. So mind over body is what we talk, especially in marathon runnings. Again, as I age, I'm thinking body is more important than the mind. So respect your body and listen to it. So always I say, choose from today's fitness or tomorrow's sickness. And exercise is $1 billion drug which never gets prescribed. Tobacco and diabetes. Quitting tobacco causes 40% risk reduction of developing diabetes. And alcohol, this is the levels what is recommended by the ADA. Strictly speaking, we don't recommend it, but when you take it, try to be in your limits and watch for hypoglycemia, especially for the diabetics. Again, one most important entity, what we forget about is about sleep. The Irish proverb says a good laugh and a long sleep are the best cures in the doctor's book. That looks like my younger son, actually. It is not. Yeah, but he does that most often. Sleep quality is commonly impaired, uncommonly assessed, and rarely addressed. I won't get in there. Why I say that is 1/3 of our life goes sleeping. And how much do we take it into account when we discuss with our patient about the sleep? And if you look at the prevalence of sleep disorder is about 58% in type 2 diabetes. And if you look at the duration of sleep and the quality of sleep, again, it has a U-shaped curve. 6 to 8 hours is possibly ideal. Obstructive sleep apnea is one of the entity which is strongly related to type 2 diabetes. Again, a large topic in itself, and it is also related to A1C. So again, I come back to my guru, Sanjay Rao sir, the Mercedes-Benz sign he keeps telling. That's how we need to divide our day, 8, 8, and 8. But I don't know how many of us are doing it. And this is the sleep hygiene what we need to follow and also to recommend. So we have moved from diabetes pathogenesis to triumvirate, to octate, to sweet 16, to dirty dozen. But somehow I feel sleep was lost somewhere. So my opinion is, in the pathogenesis of type 2 diabetes, maybe we have slept over sleep as an important entity, and it has to come into the pathogenetic mechanism in a bigger way than what we talk about it. We looked at testosterone, ferritin, so on and so forth, but somehow sleep is being left behind. So is it all just the talk, or is there a walk what Manohar has done? This is where I thank Credo for partnering with my patients. So precision medicine has been going on throughout the day. So I just look at the data what we showed. About 500 odd patients in the last 1 year I've been following up. And age is not a barrier. Again, I'm practicing in a 5-star hospital, so maybe the patients are more affordable. And then again, above 60 years also, many of the patients were enrolled into this. Duration of diabetes varied from new onset to many long duration of diabetic and pre-diabetic diabetic. So what actually happened with them, I would like to summarize in this slide. There was over a period of 3 months, some of them extended, many of them didn't extend the program because of the cost and whatever. So weight reduction in most of them were an average of 3.2 kilograms. Both systolic and diastolic BP also reduced. HbA1c reduced up to 1.2%, and even triglycerides showed a clinically significant benefit of reduction from the mean baseline of 58 milligram per deciliter. So it is not just the talk, there is some walk there, and there is a strong evidence to back up, provided we stick to it. So this is the 5 commandments or for a healthy lifestyle as a prescription, what we need to think amongst ourselves. Love yourself. I keep saying, reserve an hour a day exclusively for yourself. Do your exercise or yoga or a hobby or something. 1 hour a day is for you. Nutrition, what you eat, when you eat, how you eat, and how much you eat becomes important. Fitness is not just the exercise plus physical activity. Mindfulness is very, very important. To be mindful, I can't be like someone else. Someone is someone else and his life is different from my life, so there's no point competing there. And self-discipline, all these things will work only if we are self-disciplined and try to do most of the days, except today is a cheat day. Anyway, so lifestyle disease needs primarily lifestyle solutions. Healthy medical fraternity is the key to healthy society. We all have seen the data where doctors' lifespan is lesser than the average human being's lifespan, even in our country. And simple measure what we need to do from today is just to practice what we preach, which is, we all know that doctors are the worst patients. And if we try to practice what we preach, that's good enough. And don't forget, we are the heroes of our life. Treat yourself like a hero. And that's how I conclude. Thank you very much for the patient listening.
Dr. Shekhar sir and Dr. Sanjeev Rao sir to come on the dais, please.
Ladies and gentlemen, I'm going to hold him responsible for not calling us earlier. So you all join your hands, we'll bash him to death. Now, I'm reminded when I was sitting there and listening to many people, there were background noises and front noises. Silence is golden. You all agree? But when you open your mouth, see to it that the words that come out of your mouth will definitely prove this adage, silence is golden, is wrong, and he has done this. Let's give him a thank you. And it's not just, I have been watching, I was telling another hero, I've been telling this stupid fellow, give up medicine, become a hero in Hollywood or Bollywood, you will do better. Ravin, please stand up. Let them agree with me. These guys in the past, almost 7 or 8 years, sir, I have been watching them. I'm old now. They have really, filled the shoes of very senior people of KRSSDI in a very able manner. Fantastic work they have done. And you are seeing the reality of the best work that has been done. Can we give this stupid fellow a stand up on the bench? Wish. Thank you. And his team, of course, not just, Srinivas Murthy is here. 16 years of clinical research, no hair on head. And 20 years of clinical practice, lot of hair on head in our head. This is, placebo effect or whatever you want to call it. This is it. Thank you, thank you, thank you.
Didn't have it positive. Voice.
Ladies and gentlemen, I stand before you rather tongue-tied. I have here some of them who have worked with me and probably learned this fellow. After I have given him a bit of a mind at once or twice. Vijay, him, they're all successful consultants. And if they prosper in life, that I think is the greatest thing a teacher can do to a student. And a teacher does not need many more accolades than that. I think I have done my job. First of all. Next, unwittingly and unknowingly, Manohar now he has not taken this statement from me. As is the thought, so is the desire. As is the desire, so is the deed. As is the deed, so is the action. As is the action, so is the result. As is the result, so is the result, so is the desire. It's a circle. So if you do this, which he has done, you will succeed in life in anything. So, ladies and gentlemen, I think we should all emulate this young man and do what is, we all should succeed and be a healthy, happy life. Thank you.
Thank you so much for this informal advices given to all the delegates and the faculty that have been here. I think it's always nice to have the best for the last. And I would now request Dr. V. Mohan to address us once again and enlighten us about his lifetime of learning and knowledge.
Good evening, everyone. I'm sure you're all tired at the end of a long day, so I don't want to take up too much of your time. However, initially I thought when you asked me to be here and to deliver a keynote address, I thought I'll just give you some general ideas. Then it struck me that I'm addressing the KRSSDI, and we have data from the INDIAB study. When we publish the full results of INDIAB, each state gets lost. In fact, I would encourage each state that has done this to publish your data separately. I think 1 or 2 states have already gone ahead and done this. Haryana and a few others are doing it. So I thought I'll talk to you a little bit about diabetes in Karnataka, which is very relevant to KRSSDI. So delegates, faculty, ladies and gentlemen, students, what I'm going to talk to you is about decoding diabetes in India with emphasis on Karnataka. I have no conflict of interest to declare. These studies are by ICMR. So just a word about the ICMR INDIAB study. I think you have to give credit where it's due. Most of first of all, I started off as a clinician, and I thought that was enough. And then suddenly one day I realized that I didn't know how a non-diabetic looked like. Because I've seen only people with diabetes. So somebody asked me, how does a person without diabetes look like? I said, oh, that's a good one. I haven't seen one. So jokes apart, what I meant was, what does the normal cholesterol of somebody who doesn't have diabetes look like? So this started off on a small journey of trying to do epidemiological studies. So the first thing that we did, and Dr. Sidney D'Souza reminded me about this incident which happened. So we thought we were very good. We selected one middle income group and one low income group in Chennai, convenient sample. One of them we are doing some spiritual work with, the other one somebody came and invited us. So we said low income, high income, we'll just study that, just convenient sample. Fairly good sample size. And then we did studies. And at that time, before we published that, actually we went to, that's an incident which he reminded me about. So we took all our data to University of Wisconsin, where we met Dr. Ron Klein and showed him the data. He's a big epidemiologist. This is our first epidemiology sample. So I said, I want some time with you. And he said, yeah, sure, we'll spend some time. So he looked through the data and he kept quiet. He didn't say anything. So I said, so what do you think? So he said, I'm scared to tell you because you may get depressed. I said, well, I've come all the way from India to listen to that, so let me have it. He said, it's rubbish. It's total rubbish. So I said, why? He said, what's your response rate? So our response rate at that time was 40% or something. So we had one dietitian who was doubling up as an epidemiologist, and on Sundays she would go and do epidemiology. And so that's all she managed to do. One single person, Sunday, 1 year went, and that's all we managed to do. So he said, come with me, I'll show you my team. He had a team at that time of some 40 people doing only epidemiology. Now I have much larger numbers than that. So he took me around and he said, just talk to them and tell them what you do, he told the team. So I told them, see, we go there, but they're not coming. These are not my patients. We are going out into the community people whom we don't know, we're knocking on their doors, and many of them are not participating, they're not there. When you go there, husband has gone somewhere, somebody's gone somewhere, and so I'm not able to get. He said, that's why I want you to listen to these people. Then that's where I learned epidemiology. In that next 15, 20 minutes, I learned epidemiology. They told me what to do. You have to go back again and again and again and again. And he said, unless you get a response rate of above 90%, it's useless. Don't even publish this. So I said, okay, I've learned that. And he said, the reason you're not doing it is because you're not giving importance to epidemiology. In a spare time, you're trying to do epidemiology. Epidemiology needs a full-fledged team. So with that, I made the person who was doing it full-time, first of all. I said, you're no longer a dietitian, you're an epidemiologist. So she started doing this 7 days a week. So that improved. Then we said, that's not enough. So we had to build a second person and a third person. So with that, the CUP study got completed. So we finished CUPS, Chennai Urban Population Study. We were very happy. We said, for the first time, clinician has done a epidemiological study. We got it published, fairly decent journal, Diabetic Medicine or something, got it published. But then the criticism started coming, saying that it's not representative of Chennai. What have you done? You just picked 2 places in Chennai. Anything should be representative. So I said, what do you want me to do? He said, you have to study the whole of Chennai. Unless you study the whole of Chennai, take a proper representative sample, it's no good. And plus, with your sample size, you can't get any data on complications, which is what we wanted to set out to do, because my wife had a big interest in retinopathy. That was the first interest. So we then said, okay, then we worked backwards. Okay, if we have to have so many people with retinopathy, then we need so many people with diabetes. My initial sample size was 1,500, by the way, in cups. So I said, if you have to get so many people with retinopathy and nephropathy, then we need so many people with diabetes, at least 2,000. To get 2,000, you have to screen about 26,000 people. So from 1,000, we went to 26,000. Total representative sample. This time, we were a little more seasoned. We took little help. And then the Chennai Urban Rural Epidemiological Study, or CURES, was planned and it was done. And I remember that conversation. One of the RSSDIs from Mumbai, we are coming back. And I had Deepa Raj on the flight with me. And so they said, CUPS had meanwhile produced about 8-10 papers. So she was asking me, how many papers will come out of CURES? So I said, 100, I said. So she looked at me and she said, surely that's a joke, she said. I said, it's not a joke. You write down the first 50, I'll tell you now. So on the flight, we wrote down the first 50 papers. Finally, CURES resulted in 162 peer-reviewed publications, which is, I think, a record. Now, it was at that stage that my daughter came in now, okay? And she said, just like Ron Klein had told me, she said, you know what, Papa, can I be frank with you? So I said, okay. He said, your entire work is rubbish. I said, okay, thank you very much. At least as a daughter, you have the guts to tell me that. So I said, can you tell me why it's rubbish? It's 150 papers have come, and you're saying it's rubbish. She said, because Chennai is not India. So now see, first, it was not epidemiology at all. Okay. Then it became epidemiology, but it's no use because it's not a representative sample. Finally, you get a representative sample of Chennai, 26,000 people, you produce 160 papers, and that's rubbish because Chennai is not India. So I said, what is India? She said, India is India. I said, what are you saying? She was an MBBS at that time. So I said, what are you saying? I want to do this all India study. I said, you first finish your MBBS. Then we'll talk about all India study, okay? During MBBS, you're going to do all India study. Are you crazy? Then she finished MBA. She said, now let me do. I said, don't you want to do MD? MD is a full-time job, and you can do some research, but you can't do all over India gallivanting. You cannot do during MD. You finish that also. My hope was that she'll forget. By the time MD and all is over, she'll forget, you know. It's like somebody comes and tells you, I love this girl. Okay, you get married after 3 years. The thing is, you think that you'll forget that girl in 3 years' time. Okay, my father did that to me, by the way. But I didn't forget. Okay, so she finished her MD, and she said, now I want to do the study. So there's a day when, I'm just telling you this because the history of all this you should know. So there's a meeting in Delhi, the Indo-French meeting, and Dr. Ganguly was there. So she told me, you better tell him about the study. I forgot. So we finished this thing, the cold winter day, I remember it was January, and he got into the car. Then I remembered, God, I'll have to go back and she'll ask me. So I went running to the car and knocked on the, on the window. And he lowered, oh, yes, yes, Mohan. I said, sir, his daughter has this crazy idea, She wants to study the whole of India and do a study like that. Then he said, who said it's a crazy idea? Come next week, ask her to come and present. He said, we have not even thought about it. We only discussed that such a thing is there. He gave 1 week. So in 1 week, we went and said, okay, this is going to be in-diab study. We didn't give the name then, that came later. He said, India study. He said, north, south, east, west, one in northeast, maybe one in the middle. That's it. We'll select one state in each place. So there is a plan. We went and presented to INDIAB. We went and presented to ICMR. They listened to it and they said, no way. You either do the whole country or you don't do it. I said, why? We're doing north, so everywhere they've done. China they've done that. No study in the world has studied the whole country, by the way. US has not done it. Australia has not done it. Japan has not done it. Germany has not done it. China has not done it. Nobody has done it. When you say a national sample, it will be here, there. So I said, everyone is doing that. No, let's also do that. They said, no. In India, state is a health subject. So each state, if you do Tamil Nadu and then bring it to Karnataka and say, here, this is the thing, Karnataka will throw it out. They'll say, no, we want our data. So no state will, it's like a country by itself, each state. So they said, you have to do the whole country. So I asked her, what do you say? We'll do it. I said, okay, you do it. Not we, you will do it. So that is how 15 years ago, this study got funded. It became the world's largest epidemiological study ever done in the field of diabetes. The original plan was to study 29 states and 2 union territories. That became 30 states because Andhra got divided in between. Okay, and then 124,000 we couldn't do J&K because that got divided. We are doing it now, and all the islands got left out. We're doing it now. So we're doing Andaman, Nicobar, Lakshadweep, Daman, Diu, all that we're doing now. It's going on right now. It's almost over. And Jammu and Kashmir is also over. But that was not done. But for that, so INDIAB was also, we are not published as much as cures and so on because we wanted to finish the whole country before we start publishing. We start publishing in between bits and pieces. Then the final study won't get published. So halfway through we published one when we finished 15 states. Then when we finished all the entire country, 17 states, this was published on 7th of June 2023. And I must tell you the reaction which happened when this paper got published, because the previous IDF report had shown that there were 72 million people with diabetes. Suddenly, the number increased to 101 million. This kind of shook everyone, including the Prime Minister's office, including the Health Minister's office. Early in the morning, I'm getting calls. Health Minister wants to talk to you. Somebody wants to talk to you. Prime Minister's office wants to talk to you. What is this? What's happening in India? What is this 101 million you're talking about? We said that's the truth. That's the study of the whole country. What do we do now? People start asking us what to do. I said, don't worry, I've got a solution for it. Tell the whole people that you've got 136 million people with pre-diabetes and you will prevent diabetes in all of them. Great idea, they said. Great idea. This will be our selling point. So within 1 hour, BBC and everyone were with the DG, ICMR and saying, in fact, BBC called us and said, India is finished. India is finished. Nothing is finished. How will you manage 101 million people with diabetes? How are you going to offer care? They develop a kidney problem. What will you do? I said, if we have the wherewithal to do a study like this, we also have the wherewithal to look after. You please look after a small country. Your small country came and ruled us some time back. You continue to be bothered about your own country and leave our country to us. We know how to manage. You don't have to get overtly worried about our country. You've got enough problems of your own. You stick to your own country. Actually, we told them that. And then the BBC will put the phone down. They're trying to corner us. Okay? So this is what came out. The first metabolic NCD report of the whole country. And here are the numbers. 101 million people with diabetes, 136 million people with pre-diabetes, 315 million people with hypertension. Look at abdominal obesity, 351 million people. How many of you in the audience know of countries with more than 350 million? Countries, whole country, everyone included. How many are there in the world? No. How many countries in the world have a population of more than 350 million? Only India and China. No other country, even the United States is less. So we have got more people with central obesity than the entire population of the United States. That is why people are getting rattled, you know. And these are the actual numbers. And this is only the tip of the iceberg. It's now going to grow, grow, grow. We haven't even reached the saturation point. So you're going to see much, much larger numbers in the years to come. Let's look at diabetes. 16% urban India. Now, this is not cities. Cities we have crossed 25% long ago. Delhi and Chennai, about 10 years ago, we already reached 25% of the adult population. This is, when you say urban, we're talking about tier 2, tier 3, everything put together. For example, if we did Karnataka, there will be only a small contribution from Bangalore, a small proportion from Mysore, okay? Because urban is not Bangalore. It is proportion to Karnataka's population, what is in Bangalore only will get included. Belgaum will get included, everything will be included in that, okay? So 8 to 9, almost 9% is rural. If you remember Professor Ahuja's studies 50 years ago, it was 1% in rural. Today, whole country, we are talking about 10% of the 9% of the population in rural India having diabetes. That's huge. And those are the numbers. If you see red, it means high prevalence, more than 10%. Entire India, except one state, is red. Rural, there's still a lot of green, which means it is low, but it is going to go. This is only diabetes. If you look at pre-diabetes, you'll see that the rural is also red. Remember this figure of rural. Now let's come to Karnataka. The prevalence of diabetes in Karnataka is 10.6%. Now this is whole of Karnataka, urban, rural put together. That means the entire population of Karnataka, adults about 20 years of age, almost 11% are already having diabetes. Okay, more than 1 in 10 are already having diabetes. This is from the poorest to the poor to the richest. All are included in this. Pre-diabetes. Pre-diabetes, if you thought diabetes is high, pre-diabetes is even higher. Now what does that mean? It means that the epidemic is not over. You're going to get more and more feeding into diabetes from the pre-diabetic pool. When we can all celebrate is when the pre-diabetes numbers go down. That means you're not going to get anything feeding in diabetes. The epidemic is almost getting over, saturated. We have not reached that point. Over the next 5 to 10 years, you will find steady increases in diabetes because it's pre-diabetic pool. Unless we all start a huge campaign to prevent diabetes in those with pre-diabetes, okay? And you can see here the rural is 15%, and that's why a lot of red there. When you saw the rural map for diabetes, all green. There's hardly any red. Look at the reds there. Now, the southern states, which had a lot of red in diabetes, are already beginning to have lower rates of pre-diabetes. So, we are beginning to saturate a little bit. But states like Uttar Pradesh, which is a country, it will be the 4th or 5th largest country in the world, if UP was a country. Okay. Luckily for us, the prevalence of diabetes is lowest in UP today. It's 4.8%. It's the lowest in the whole country. If UP goes up by just 1%, 2%, the numbers will go up by millions. And it is going to happen because there's a lot of pre-diabetes. You can see that area is completely red as far as pre-diabetes is concerned. So you're going to find huge increases occurring in UP and all that quite shortly. Now Karnataka, 13% is the prevalence of pre-diabetes. And if we take the diabetes to pre-diabetes ratio, it is 1 to 1.2, which means there's more pre-diabetes. When that ratio becomes 1 is to 0.4 or 0.3, then we know, yes, now we're reaching only those whom we have to look after. No new ones are going to come. Because by the time you treat these, more will come. By the time you treat those, more are going to come. So that is the problem that we are facing today. What about obesity? Can you imagine that if you look at generalized obesity based on BMI, 40% of urban India is obese, 40% of India is obese, and 23% of rural India is obese. We think they're all very thin guys in rural area. Think again. There's a lot of obesity coming in rural India. Rural India has more people than urban India. So a slight increase there will mean much more obesity and much more diabetes in rural India. This is abdominal obesity. If you take whole of India, all urban areas put together, 1 in 2 is obese. 50%, 51%. Half the population of urban India is obese. This is huge. And rural is 1 in 3. It's not far behind either, okay? And that's abdominal obesity, whole country, urban, rural. You can see a lot of red in the rural as well. And here's Karnataka. Generalized obesity almost 27%, and the abdominal obesity is 35%. 1 in 3 of everyone in Karnataka is obese. Everyone in your state, 1 in 3 is obese. Hypertension. Hypertension is 40%. Now, these are much higher than reported earlier by NFHS and other surveys. They've shown 28, 30, 32%. Here in urban, it talks about 40% hypertension, 33% rural, and overall for the whole country, 35%. 1 in 3 of all adults in India have hypertension. Karnataka, almost the same. 1 in 3 have hypertension. Cholesterol. This is defined as a cholesterol, total cholesterol more than 200 or an LDL more than 100. Urban, 27%, rural, 22%. And the overall prevalence of Karnataka, hypercholesteremia is slightly lower than the national average. You can imagine how it is in Kerala and Goa, where coconut oil is taken. It's huge. It's one of the highest. And the other big state where cholesterol is very high is Punjab, where a lot of butter is eaten. So we think, and we are told, that this cholesterol thing is a myth, that you take saturated fat, nothing happens to you. Think again. We've got epidemiological data. The only problem is, these things are so politically sensitive, that if I now go and say that in Kerala, due to coconut oil, it went up, I'll be probably killed by some activist or somebody. You know? So we're scared even to project our own data. You know? That's the truth. So here's your summary of the Karnataka data. 10%, 10.6% diabetes. You can take a picture of this. 13.7% pre-diabetes, 31% hypertension, 27% generalized obesity, 35% abdominal obesity, and 17%. The only thing you have a little lower is cholesterol. That will be worth studying. Why one state has only 17% cholesterol and a neighboring state has so much? Because oil is an obvious one, but there are other things. These are all things which can lead to next 20 years of research can go on based on these findings. Now the problem is, as already shown and shown by your president just now, the NCDs all are increasing, physical activity is low even among the rural people, rapid changes in diet are occurring in your own state, and 70 to 80% of what people eat in Karnataka is mostly carbohydrate, very little protein. So what can we do about it? I just put down 2 or 3 things generally, because in RSSDI you should be thinking about these. What can the patient do? We've talked all about that. The ABCD, let's not forget the ABCD. I think in every conference, we should emphasize and re-emphasize the need for ABCD. I'm not going to go through all this. Your president talked about all this so well. At the provider level, that's at the patient level. At the provider level, screening, and we have given awards for screening today. I think that's very, very important, because diabetes is asymptomatic and pre-diabetes is totally asymptomatic. How are you going to pick up these guys who have even more than diabetes? And the heart risk is as much as those who have diabetes. Unless you go and screen, you're not going to pick them up. So in every district in Karnataka, you should have, and I know that RSSDI is setting up at every district NCD officers and diabetes screening and so on. In every district, you should have champions who will go and screen for diabetes, pre-diabetes, and spread the message. That's the only way you can make an impact. And of course, the need for ABC control and so on. At the government level, we need a lot of support. We need policy decisions. When we talk about fruits and vegetables, if you look at that map in INDAB 17 published in the June issue of Lancet Diabetes, the fruit and vegetable intake in our country is horrendous. It's very, very low. Physical activity is even worse. If you look at it, it's completely red, which means near zero physical activity in every state in this country. And yet, we cannot afford even our tomatoes. We cannot afford onion. We cannot afford simple things in life. This is the government's job. This is not our job. They have to make healthy things cheap. If you keep healthy things very expensive, people will not eat that. They'll go to the nearest fast food shop and buy. That's what happens in the US. McDonald's is much cheaper than going to a grocery store and buying an apple. They can't afford it, the poor people. Can't blame them. That's what they get for $1, $2. They can eat all that they want. And that's why obesity is going up. Same thing is happening in India. It will continue to happen in India unless we change the policy. Laws, regulations, spaces, open space for people to walk. I just posted this morning, what a pleasure it was staying in the Indian Institute of Science guest house. And every time I go there, my morning walk is something I enjoy. Forest, nature, even there are footpaths within to walk. It is so safe and absolutely good. How many such places do we have? Maybe Bangalore has a little more. In Chennai, there is nothing. You cannot walk in Chennai. And all the floods and all you can expect, I predict every year we'll get the same floods. Because there's no place, everything is taken up. Construction, all the thing is gone, roads are gone, footpaths are gone, everything is gone. There's no city left. So when you have that kind of a thing, where are people going to walk? When I tell my patients to walk, they'll say, either a dog will bite me, or the pollution will kill me, or a truck will hit me. So they say my lifespan will go down if I go for a walk. It's probably true. Not everybody lives in Koramangala and Boat Club, you know. So where do the poor people go? At least we have a beach, somewhere they can go, okay? There are no places for people to go. These are things which they should do, by cycling places and strengthening healthcare to look after. We say ABCD, but ABCD for 100 million people, getting that under control, it's not a joke. And by the time you do that, it will become 120 million. By the time you do that, it will become 150 million. It's a no-win situation at all, okay? So is there proof that if we do all this, they can live long and healthy lives? This is the paper for which I got the Harold Rifkin Award. I was surprised when they gave me this award. Then when I got it, and on the stage, Will Safalu was there, and he had published this paper actually, in Diabetes Care. He was the editor of the journal, and he was giving off the award many years later. 2013 I published, 2018 I got the award. By the time he was no longer the editor and so on. So when I went up to the award, he was announcing it. So I said, do you remember me? Because he came down to Chennai when he saw this paper, because he wanted to see it. And what he made me do was, I reported for the first time in the world on long-term survivors of type 2 diabetes with 50-year survival of type 2 diabetes. Type 1 is known. Children, you can live 40, 50 years. But type 2 was the first time it was shown. What he came to Chennai to tell me was, I like this paper, but I'm not going to publish it until you have a control group. And the control group is non-survivors. You must show people who died. And now only you can do it. You show how they lived and how the others died. If you're able to do that, it's a classic paper. It'll become one of the classics in diabetes. And it did. So I've forgotten all that. So when I went up 5 years later to receive the award, I said, do you remember me? He said, why do you think you got the award? You got it for that paper. I said, oh my God, I didn't even realize it. I didn't even connect. So, but what came out of the paper was very simple. Those who survived had better glycemic control. What is that? A1C. Better blood pressure control. What's that? B. And better lipid control. What is that? C. So my A, B, C came from this. It didn't come from anything else. We didn't make it up. It came from this paper. It's actually based on evidence. Okay? And then we also showed that people can live up to 90, even 100 years. And this picture, which I'm very fond of showing everyone, is that there are two people in that room who are below 90 years of age. I hope you can spot them at least. I hope you can spot them. I hope you don't look 90. So there's one guy standing there and one lady, young lady next to him. That's my daughter. So two of us were below 90. Everyone else in this room, when the picture was taken, was above 95. One second sitting in the wheelchair was 101 years old, and he was our chief guest. He was the former vice chancellor of the university, and he was the chief guest. The one next to him was 97 years old. He was the chief secretary. He had worked with 3 prime ministers and 3 chief ministers of Tamil Nadu. And at the age, he was 97 when he came to the picture. At 96, he had written his book. His faculties were completely there. He walked in. In fact, he shouted at me because he was 1 minute late. I told him to come at 10, and at 10:01 I walked in. Not that I was late. I'm never late. But I told my secretary, sir, nobody in the hall, sir, nobody in the hall, sir, nobody in the hall. So at 10:01 I walked in. And he looked at it and said, what time is it? 10:01. What time did you tell me to come? 10. You should have been here 5 minutes earlier. You didn't come, he said. So that's the kind of man he was. He continued, he finished his 100th birthday, and after 101 years, he recently passed away. Many in this group have already crossed 100 years of age. They're still alive, okay? So it's possible for people with type 2 diabetes to live up to 90, 100 years of age. And I keep saying this all the time. Some of you might have read my editorial in the Hindu on World Diabetes Day. I said reversal of diabetes, desirable but not essential. Desirable, yeah, you get it? It's great. Not essential. None of them had reversal. They're all taking treatment. They're all taking medicines, okay? And one thing they all did was they came regularly for follow-up. And they all walked, by the way. They all walked and came. Many of them walked up the stairs when they came for this. So it's possible to get that. So to conclude, ladies and gentlemen, the prevalence of diabetes in Karnataka is 10.6%, but we have more pre-diabetes. The ratio of diabetes, pre-diabetes is still undesirable. We have a lot of hypertension, a lot of dyslipidemia, and the most important thing in treatment of type 2 diabetes at least remains lifestyle, and diet and exercise, sleep, and whatever else you want to put into it will come right on top. Before I end, I was listening to the debate, and Arvind had asked me to respond about the older drugs versus the newer drugs. All those guys whom you saw in the picture, not one of them had used a modern anti-diabetic drug. 60 years ago, 70 years ago, when they got diabetes, they had only metformin, and the cheapest of sulfonylureas, the oldest sulfonylureas, is glibenclamide. That's all they had. Many of them continued that till now, even in their 90s. My grandfather got diabetes when he was 44. He died when he was 99, after 55 years. My father was treating him, and he was on glibenclamide only till he died. At the age of 99, he was still taking glibenclamide. Nothing happened to him. We never saw him once in a hypoglycemic coma. So, yes, it is true that these drugs do have side effects. Many of them are exaggerated. So it doesn't matter what drug you take. It's not because of SGLT2 that they survived. It's not because of degludec that they survived. Okay? They survived because they walked, they took their exercise, they took some small dose tablet, they came for checkup. I'm not at all decrying the modern drugs. They are fantastic. They should get a Nobel Prize for all the discoveries that have been made. But that's not the main reason why people live. That is not why people live longer. Treatment of diabetes, management of diabetes has much more to it. So don't worry if your poor man in the rural area could not afford Ozempic. Okay? It doesn't matter. There are many other ways of treating. Okay? If you can afford it, give it to him. Or give it free to someone, you give it. But that's not the one which is going to make him live a long and healthy life. It's common sense. It is our commitment to them. It is our guidance. We are mentors to them. So if we take care of that, and I want everyone in the audience today to take a pledge that you will reduce the A1C of all your patients who don't have the good control by at least 1%. That's a very easily doable target. If every one of you in this room, every one of your patient who has uncontrolled diabetes, just by 1% you reduce your A1C in the next 6 months, that's far more important than conducting the 21st annual conference or the 20th annual conference of KRSSDI. That's a far greater contribution to society. Because that is what we are all living for. That is why we have become doctors. And in the process, also look after your B and your C and your D and E and F and whatever you want to do. But keep the patient on the top of your agenda. We are all working for the patient. I think Dr. Lily John said that. All the old-timers like Dr. Lily John and me will say that, because we always had our patients in mind. All other things came secondary. And I'm sure if we all work together, it doesn't matter if the number of people with diabetes went from 100 million to 200 million. So what? If they all are going to live up to 100 years of age, like 500 million people in India get diabetes, who's bothered about it? It's our duty to see that they all have a long and healthy life despite diabetes. Thank you.